What essential hormone screening is needed if an unexpected adrenal mass is found? An adrenal mass found by chance can create immediate concern, but knowing exactly which hormone tests you need can transform uncertainty into informed action through evidence-based content curated by Saboor, fellowship-trained consultant surgeon. An adrenal incidentaloma, a mass detected on imaging not performed for suspected adrenal disease, is found in approximately 3 to 5% of computed tomography scans performed for unrelated reasons. Most incidentalomas are non-functioning adrenocortical adenomas, which are benign tumors of the adrenal cortex. However, some require intervention because they may represent adrenocortical carcinoma, a cancer of the adrenal gland, or Pheochromocytoma, a tumor that secretes catecholamines. These chemicals cause high blood pressure, or hormone-producing adenomas producing high levels of cortisol, or metastases from cancer elsewhere in the body. These tests are essential in patients with symptoms. Why this matters to you personally? Despite current guidelines, research shows the majority of patients with adrenal incidentalomas still do not undergo the recommended hormonal workup. This gap between recommendation and practice means potentially dangerous hormone-secreting tumors can be missed. Even when an adrenal mass appears benign on imaging, hormone testing remains essential, because hormone excess can occur without obvious imaging features, and missing conditions like pheochromocytoma can lead to life-threatening complications during routine medical procedures. Before we dive deeper, let's establish which tests you actually need. Every patient with an adrenal incidentaloma, 1 centimeter or larger, should undergo a 1 milligram overnight dexamethasone suppression test to exclude autonomous cortisol secretion, meaning the adrenal tumor produces cortisol independent of the body's normal control mechanisms. Here is how the test works. You take 1 milligram of dexamethasone, a synthetic steroid, at 11 p.m., and your blood cortisol level is measured the following morning between 8 and 9 a.m. The critical threshold you need to understand: serum cortisol levels at or below 50 nanomoles per liter, which equals 1.8 micrograms per deciliter or less, exclude autonomous cortisol secretion. That means if your cortisol suppresses below this level, you do not have cortisol autonomy and need no further endocrine follow-up for this finding. International guidelines now use this single cutoff because evidence shows it differentiates patients at increased risk of complications from those who are not. The image shows effects of high levels of cortisol. But here's where it gets interesting. If your post-dexamethasone cortisol is above 50 nanomoles per liter, you have what experts now call mild autonomous cortisol secretion, abbreviated MAX. This replaces older, more confusing categories. In patients with MAX, guidelines recommend confirming that adrenocorticotropic hormone, ACTH, the hormone that normally tells your adrenals to make cortisol, is suppressed, which proves the cortisol excess is coming from the adrenal tumor itself. A repeat test is recommended to confirm this finding before making treatment decisions. The test has important limitations. Certain medications can interfere with results, including oral contraceptives, hormone replacement therapy, and some seizure medications. We recommend excluding pheochromocytoma by measuring plasma-free metanephrines or urinary fractionated metanephrines, breakdown products of adrenaline and noradrenaline, but this recommendation is now refined based on imaging. Recent multi-center studies show that adrenal tumors with Hounsfield units, a measure of density on CT scan, of 10 or less, have virtually zero chance of being pheochromocytoma. That changes from 1 in 1,000 to essentially 0. Therefore, if your unenhanced CT clearly shows features of a benign adenoma, meaning homogeneous appearance and Hounsfield units of 10 or less, measurement of metanephrines may not be necessary. Why this matters so critically? Pheochromocytomas can cause life-threatening blood pressure crises during surgery, biopsy, or even contrast imaging studies. Missing this diagnosis before such procedures can result in severe complications or death. The test uses either plasma-free metanephrines with blood drawn while you are lying down, or 24-hour urinary fractionated metanephrines. Both have excellent sensitivity, meaning they rarely miss pheochromocytoma when present. Guidelines recommend using the aldosterone-to-renin ratio to evaluate primary aldosteronism, a condition where the adrenal gland produces excess aldosterone hormone, but only in specific circumstances. This test is recommended in patients with concomitant hypertension, which means high blood pressure occurring alongside the adrenal mass, or unexplained hypokalemia, meaning low potassium levels in the blood. This selective approach is evidence-based. Primary aldosteronism occurs more commonly in hypertensive patients with adrenal incidentalomas than in the general hypertensive population, but remains relatively uncommon in normotensive patients without potassium abnormalities. The aldosterone-to-renin ratio involves measuring both aldosterone and renin, another hormone, from a single blood sample, ideally drawn in the morning after you have been up and moving for at least 2 hours. If you are worried about someone you love with high blood pressure and a newly found adrenal mass, ensuring they receive this screening can identify a potentially curable cause of their hypertension. Treatment of primary aldosteronism, whether with surgery or specific medications called mineralocorticoid receptor antagonists, can significantly improve blood pressure control and reduce cardiovascular risk. Current evidence shows that testing for other hormone excess is either universally recommended for specific findings or reserved for particular clinical scenarios. For virilization, development of male characteristics in women such as rapid onset of excess body hair growth, deepening voice, or male pattern baldness, measurement of testosterone and androgen precursors including DHEAS and androstenedione is warranted. Recent onset of gynecomastia, breast enlargement in men, should trigger measurement of serum 17-beta estradiol. For patients with bilateral adrenal masses, additional testing becomes relevant. Now you might be wondering about repeated testing during follow-up. For patients with initially non-functioning adrenal incidentalomas, systematic hormonal follow-up is not recommended because the risk of developing clinically relevant overt hormonal excess is extremely low. 0 to 0.6% for Cushing syndrome, 0 to 1.6% for primary aldosteronism, and 0 to 2.1% for pheochromocytoma. However, if you develop new symptoms or significant worsening of conditions like diabetes or hypertension, hormonal reassessment should be performed. If you have been told you have an adrenal incidentaloma, confirm with your physician that you have undergone or are scheduled for a 1 mg overnight dexamethasone suppression test. This is the universal screening test recommended for all patients. Gather your imaging reports and look for the unenhanced Hounsfield unit measurement. If this is 10 or less with homogeneous appearance, your risk of pheochromocytoma is essentially 0. If this information is not in your report, or if Hounsfield units are above 10, ask about metanephrine testing. Check your blood pressure at home for 1 week, morning and evening, keeping a log. Discuss with your doctor these important questions. What were my exact post-dexamethasone cortisol results, and what do they mean for my specific situation? Understanding whether your result is below 50 nanomoles per liter versus above this threshold fundamentally changes your management pathway and follow-up needs. Based on my imaging characteristics, do I need pheochromocytoma testing? Be specific about Hounsfield units and whether your CT was performed without contrast. If your doctor recommends biopsy or surgery, confirm pheochromocytoma has been excluded first. Seek urgent medical attention for severe, sudden headache with palpitations and sweating. This combination suggests possible pheochromocytoma crisis. Do not undergo any surgical procedure or imaging with contrast until pheochromocytoma is excluded if your imaging features were atypical. Contact your physician promptly for rapid development of symptoms suggesting hormone excess, easy bruising, muscle weakness, rapid weight gain concentrated in the trunk and face, uncontrolled diabetes despite medications, or resistant hypertension requiring 3 or more medications. For women, rapid development of male characteristics including voice deepening, severe acne, or excess facial hair warrants urgent evaluation. Let me quickly recap. 3 hormone tests form the foundation of adrenal incidentaloma evaluation: the 1 mg overnight dexamethasone suppression test for everyone, pheochromocytoma screening for masses without benign imaging features, and aldosterone testing for those with hypertension or low potassium. Your next step: ensure you have appropriate testing scheduled and understand which category applies to your specific situation. This information is for education. Always discuss your individual situation with your healthcare provider. The European Society of Endocrinology Clinical Practice Guidelines on Adrenal Incidentalomas provide comprehensive, evidence-based recommendations updated in 2023. The Endocrine Society Clinical Practice Guidelines on Pheochromocytoma and paraganglioma offer detailed protocols for metanephrine testing and interpretation, including management of borderline results and factors affecting test accuracy.